Thank you for joining us today for our Facebook Live session, Treating Anaphylaxis with Epinephrine Auto-Injectors and When to Use a Second Dose. I am Ranjit Dangel, VP of Education and Engagement at Food Allergy Canada, and our guest speaker today is Dr. Julia Upton. It is Food Allergy Awareness Month, and this session is a part of our Know It, Treat It campaign to empower all Canadians and take the fear out of anaphylaxis. I'll talk more at the end of the session on how you can get involved, including a chance to win a Visa gift card. In today's session, Dr. Upton will review the different epinephrine auto-injectors in Canada for treating anaphylaxis, and she'll do a demonstration on how they're used, helping you learn which ones might be best for you. You'll also gain a better understanding of the signs and symptoms of anaphylaxis and when to use a second dose of epinephrine. If you have an epinephrine auto-injector training device, have it handy so you can follow along during the demos. If you don't have one, that's fine. A training device is not required for today. Before we get started, I wanted to note a few items. This session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please do speak to your doctor about any concerns you may have about your health or the health of your child. If you have any questions during the session, please ask them through the comment box. We'll try to get to as many questions as we can. And this session will be recorded and shared on Facebook and on foodallergycanada.ca afterwards, so you can watch it again and share it with others. And now I'd like to introduce Dr. Julia Upton. Dr. Julia Upton is a Canadian allergist who is on staff at the Hospital for Sick Children in the Immunology and Allergy Department, and she is an associate professor in the Department of Pediatrics at the University of Toronto. Dr. Upton is on the board of directors of the Canadian Society of Allergy and Clinical Immunology, and she's a member of our Healthcare Advisory Board. I'll now share some slides for Dr. Upton to cover on the basics of anaphylaxis and how to treat a reaction. So just give me 1 second while I get them up for you. There you go. So Dr. Upton, let's start with what anaphylaxis is, including the signs and symptoms.
Great, thank you so much, Ranjit. So, often we talk about anaphylaxis in very scientific terms, and today we're going to talk about it in kind of more practical terms. And rather than the study definition of anaphylaxis, we want to think about it in what does it mean for you. And so although we always say anaphylaxis is potentially life-threatening, that does not automatically mean that it will be. I mean, very fortunately, fatalities are very rare, but they can be hard to predict. And that's why we really want to treat anaphylaxis knowing that potential. So the most dangerous symptoms are difficulty breathing, so symptoms affecting the chest or the throat, or a drop in blood pressure, so symptoms of dizziness or feeling faint or weak, etc. And so we can see here that the other symptoms are itemized in these pictures. So we can have skin symptoms such as hives or swelling or itching or redness. We don't always have hives with an allergic reaction, and so it's important not to rely on those. I would say most of the reactions have hives plus something, but not always. And so that's not the only symptom to look for. And then, we mentioned the breathing symptoms. So coughing, wheezing, shortness of breath, the chest pain or tightness, also throat tightness or hoarse voice. Some people have a lot of nasal symptoms where it almost looks like hay fever type symptoms, very, very stuffy, very blocked nose, runny nose, itchy, grabbing tissues, that kind of thing, as well as the eye symptoms of watery eyes, redness of the whites of the eyes, and then sneezing, trouble swallowing, choking, those kinds of symptoms. Then the stomach symptoms of nausea, pain or cramps, vomiting or diarrhea. And the stomach symptoms, we think of the stomach symptoms now as where the food touched. So it's maybe not that surprising that many of the allergic reactions have quite a dominant stomach symptom, because many of us know what does it look like when we put the food or the food extracts on the skin and do the scratch test, and we can imagine when that food is touching the GI, it's kind of causing that same allergic reaction where it touches. And then the heart symptoms, you can see they're looking pale or feeling dizzy or lightheaded. And so we just have highlighted in this slide that it's the breathing or the heart symptoms that are really concerning, and that having the breathing or heart symptoms or throat is included in breathing can be just alone indicative of anaphylaxis. And so if there's a question, then treat it.
Thank you.
Mhm.
Now, can you cover the different types of epinephrine auto-injectors available in Canada?
Absolutely. So right now there's two types of epinephrine auto-injectors. So there's EpiPen, which comes in 2 doses. There's the EpiPen Junior, which is 0.5 milligrams, and that's for people for 15 to 30 kilos, according to the label. Many in the audience will know that often allergists switch to the bigger one, the 0.3 milligrams, the regular EpiPen, at about 25 kilos, just because the child's going to continue to grow, and the ideal dose is about 0.1 per kilo. So we often switch at about 25. Some people's practice is to switch at 22.5, but those are the labeled indications. And then there's Allerject, which also has those same 2 doses. So the 0.15, which is the junior, and the 0.3. And I have them with me, and we will demonstrate them later. The big difference between the 2 of them, I mean, certainly they look very different. Here's the demonstrators. Certainly look very different, as you can see in the picture, in the slides. But also that many people are very familiar with this device, the blue to the sky, orange to the thigh, which we'll show later. And then this one talks, and that's and it has a very different form factor. In terms of the drug itself, though, and you can see the doses for the junior and for the regular, they're exactly the same. So the medication is the same. It's the form factor and the kind of the talking that's different.
Great. What about the location of the injection?
So the location is the upper outer thigh, as very nicely described in this picture. I often like to think about the seam, and so I like that picture in the middle, that really you can imagine that the seam of those shorts would be behind that. And so I always say it's in front of the seam in the upper outer part of the thigh. You don't want to go around to the back of the leg. You don't want to be, you really want to stay in the front upper outer part. And this is nice because we have different pictures in different locations. Another place that's kind of helpful is that it's often where your arm kind of naturally falls, which I'll show you when we do the demonstration.
Perfect.
And maybe just to highlight, it isn't the arm. We really do prefer the leg. And the reason it's the leg is so we want a nice muscle. And so some people may have had the experience of having it in the deltoid or in the arm. The reason we want the leg is because it's a nice big muscle, and that we can get distribution of the epinephrine very quickly.
Okay, great. Thank you. Can you talk now about the body positions involved?
Yeah, so in an ideal situation, we want to be lying down, and that's because that's the preferred position for the allergic reaction itself. So when we think back to those symptoms that we were talking about, if there's a potential of involving the circulatory system or the ability for the heart to pump blood around, then we really do want somebody lying down in a nice, calm setting, and then also sometimes it can be a little bit of a struggle to give this to a child, and so you can maybe control the movements a bit better as well if the child is lying down. And it mentions there, you may actually have to support or brace the leg before giving the epi to a child. And there are some people who are feeling sick and are vomiting, and then in which case we would want them on their side. We don't, this call out box here is really important. What we don't want sudden changes in movement. We do sometimes see that somebody feels kind of okay lying down or sitting, and then they feel very not well when they have a rapid change in position. And that's because their body was kind of coping when they were relaxed and lying down, but then they weren't able to manage that that change in position, and their heart wasn't able to get the blood all the way, and they feel faint. And so we don't want that to happen. So we are very careful here about sudden changes in position, and this slide does a great job of highlighting that. And then after giving the epi, again, lying down is best. Putting the legs up again improves the heart's ability to pump that blood back to the brain. And then it highlights there on the side if somebody feels sick. And, being able to stay with the child is really important to keep them calm and to be able to watch whether they need another one. So.
Okay, great. Can you share some common mistakes to avoid when giving epinephrine? I know you mentioned before about injecting into the arm, and although that's not necessarily a mistake and why we want that in the leg, but are there other things to think about when you're giving?
Yeah, definitely. So some of the common mistakes are absolutely that we would give it in, we do see that people give it in the arm rather than the leg. I might go as far as to say that's a mistake, because we really do want it to be in the leg. Another one would be not holding the device in place for enough time. They actually do inject very, very quickly, but when a worrisome or stressful event is going on, it can be difficult to know how much time has been. And that's why we often say to count to a few seconds, just to really make sure. And when I demonstrate them, I'll highlight that as well. But just to really make sure that it isn't it's not a jab movement. It's not just an in and out. Like it's a press and hold. You really want to make sure that the device has the opportunity to fully deliver the dose of epinephrine. There's can be a problem where the device is the wrong way around, and so it is really great to get used to them. And this one is blue to the sky, orange to the thigh, but also to play with the demo, to really think about the fact that it's the back is where the cap comes off. And, if you're not used to that, it may feel like a cap would come off the front, right? But it's the back where the cap comes off. And that's a very common error, to have it the wrong way around. You don't need a hugely forceful motion to inject. The machine kind of triggers on its own, which again we'll show, but I can just show here that you can hear that the click happened, and then the needle would have come out in that setting. Another thing that I'll show you when we do the demonstration is there's no button to press. So it really is on this one that the back comes off, and then this is the demo, so I can show you on my arm, but I'll show you where it is normally, that when you push, that's the click that's making it come out. There's nothing that you need to touch on the back. So I always tell people there's really no reason to have your thumb on the back, because let's say it's a stressful situation, you have it backwards. If you don't have your thumb on it, it just won't inject. Whereas if you have your thumb on the wrong end, then you risk injecting your thumb, which we really don't want to do. So there's really no reason to have your thumb on the front or the back of this device. Hold it like this. And another thing is the device-specific instructions. So for this one in particular, you're supposed to take the back off by holding it and lifting it straight up. There are some people who, again, there's many things going on when one of us needs to use epi, and some people flick it like this. But the problem with doing that is that sort of lateral movement on the device occasionally can trigger the front of the device. So we don't want people to just flick it like this. What we want is to pull it, hold it and pull it straight up, which is what it says on the device.
Great. Those are really great insights that you don't normally necessarily think about, right, when you're using the trainer. So it's really, really helpful. Can you walk us through what to do when an anaphylactic reaction happens?
Yes, so we have the 5 emergency steps on the screen, which is great. And so step 1 is, maybe we'd even say step 0 is to be lying down if possible. So, and that's depicted in the picture. And then step 1 would be to give the epinephrine auto-injector in that upper outer part of the thigh. I always enjoy this picture because it's highlighting that you can go straight through the clothes. Of course, right there, maybe you would just lift the shorts up a little bit, but it is drawn like that for a reason, to highlight that you can go straight through the clothes if you need to. So give the epi, and then step 2 is calling emergency services. And then step 3 is to use a second one if you need. So if the symptoms aren't recovered, or if they're coming back, then to use a second one as early as 5 minutes. Often we see, that it's more that like about 15 or so or 20 when it starts to come back. But if the first one didn't resolve the symptoms, you can give the second one as early as 5 minutes afterwards. And then step 4 is to go to the nearest hospital. And then step 5 is to activate the emergency contact. So if you're looking after someone, or if this is school, or then they would call the parents and ensure that that they know about it. Now, a few things and it's in this call out box, is that it's the allergic reaction is the reason to go to the hospital. It's not the giving of the epi. So we often hear people say, well, I didn't want to give epi because I didn't want to go to the emergency department. But it's the allergic reaction that we're making the decision. Is this allergic reaction bad enough that you need medical attention? And if it is, then it's bad enough to use the auto-injector. And so it's not the auto-injector that stops you from needing to go. It's the, or the auto-injector that makes you go. It's the allergic reaction itself. And, certainly there is evolving advice that came from COVID times that, in fact, if your doctor advises you that that you fall into the category where you could give one epi, and if you're fine, then you don't need to go, that's something to discuss with your doctor. We do have a bit more latitude now where there's North American advice around that. So specifically, some of your allergists may be comfortable in your particular situation saying that if you have, or if your child has an allergic reaction and it responds very well to one dose of epi, you don't necessarily have to go to the emergency department. That really is a patient-centered and patient-directed interaction with your allergist. And so that's why we, continue to make sure that we educate on the 5 emergency steps, knowing that there may be some tweaks at the level of your personal allergist.
So that's really helpful. Thank you for that. Just to let the viewers know, these 5 emergency steps that you're seeing on the screen, they're available for download on our site, as well as a one-page sheet on the signs and symptoms, so showing similar images to what you had seen earlier. So you can print them off and put them up for really easy access. Now let's actually talk about the second dose. You talked about it a little bit in terms of when to give it, but how do you know when to give a second dose and where to give it, and what do you look for, and how long do you really wait between the doses? I know you kind of mentioned the 5 to 15 or 20 minutes. So I don't know if you want to expand, if you can expand a little bit further on the second dose.
Yeah, so you want to give the first one a little bit of time to work. So with the symptoms of anaphylaxis that we went over earlier, if the first epinephrine doesn't show significant improvement in those symptoms, then you can give a second dose as early as 5 minutes after the first one. And it can be given in the same thigh as the first dose, ideally in a slightly different spot. I'm very visual, and I picture that the epinephrine actually it's doing a lot of good things to help the body manage this allergic reaction. And so one of the things that it does is it tightens the blood vessels. But what that means is that if you give the second dose in exactly the same spot, then maybe it won't get as well absorbed. Look, it's better to give it than not give it. If that's the only available spot, give it. But if you have the opportunity to do a slightly different space, a little bit lower, or the other leg, then that's often what we do. And then, like I said, so you can give it in the same leg. We often give it in the other leg. And then it's not so much that you would only give it if it's 5 minutes, it's, 5 minutes or later, you could give it a second dose, right? So what we do sometimes see is that first one works very well, and then the symptoms start to come back. So meaning, somebody may have been sneezing and have hives and abdominal pain and wheezing, and then the epi makes all of that or most of that go away, but then it starts to come back about 15 or 20 minutes later. And so, you want to be on alert that they may need that second dose even longer than 5 minutes afterwards. So we're really watching to see, did the epinephrine resolve the symptoms and keep them resolved? And when we were mentioning earlier about, for most people, the current advice is that if you're having an anaphylactic reaction, you really do need to have urgent medical services involved, and the epinephrine is kind of the treatment until you get there, is the way that I think about it. But for some people, you may receive this advice from your own allergist, that if you had very good resolution with the epinephrine, that you can continue a watchful waiting strategy at home, with ready to give the next one if needed.
Okay, perfect. We have had a question come through, but I'll ask that question at the end, when we have some others to ask you. I'm gonna stop sharing now, and I'm going to ask you now to do the demo on how each device is given. So that's the EpiPen and Allerject. And if you do have a trainer, for those of you who are watching, follow along with your trainer. So I am going
Great,
to.
thank you. So I'm in a bit of a utility room, just so you know. So I'm going to unblur the background, because otherwise it will blur my hands and you won't be able to see the device. Great. So this is the epinephrine, like the EpiPen demo. I just want to show you the real one instead. So this is what the real one looks like. This is a used one. They're quite different, actually. The real one, the live one, has this window where you can actually see, what does the medication look like? Is it clear? Because you don't want to use it if it's cloudy. And they're very different in color. So the demonstrator is very plain in color, and it also says right on it, training device. So there are certainly differences when you look at them. And but it's always good if you're practicing to really make sure, is this the demo, and just have a look and make sure that it's the one with the plain coloring and that it actually says training device right on it. Okay, so if I needed to give this, then again, speaking of the position, ideally I'd be lying down, and then I would take this off with 2 fingers straight up. So straight up. Now the back is off. And then it's the upper outer part of the thigh. So I'll just tip this down a bit. So, here's the seam. I'm in front of the seam. My arm kind of pretty much naturally falls here in like the meaty part of my thigh. And so I would hold this. I never touch the back of these, just in case I somehow flipped it around. I never touch the back. And then I would just do this location right here, and you'll hear it. You can hear the click. I hold it. So I would count 3 or 5. So I think they say count for several seconds. So I'll say 1, 2, 3. And then you can see, as I remove it, the orange piece is now covering the needle. And so, this is a fake one. There is no needle here, but on the real one, the needle would have come out, and then as I'm removing it, the orange bit is shielding the needle. That's how it works. And so then for this demonstrator, I can now, just squish all of that back in and put the back on again and be ready to use another time. So just to do it maybe without all the talking. So I'm holding it. Great. So that's that one.
Just one quick note, although I know you're doing the demo, so it's hard to do sitting, but most people we'd recommend them sitting or laying down. Obviously, I'm not going to ask you to get on the floor and show it. So
perfect. Yes, absolutely. So lying down is ideal. I am standing largely so you can just see the location. Yeah. thank you for highlighting that. This is the Allerject. So Allerject, the demo, not everybody has a demo. You can go to the website and order one if that's certainly how we got ours. And so it comes in a little box like this. Again, plain coloring. It says trainer all over it. Tries to make it really clear. The box says trainer, the device says trainer, and it's quite plain coloring. It says trainer in huge letters. The real one looks quite different. And live one, or the one with the medication, looks quite different. Same form factor, of course, but the coloring is different, and it does not say that it's a trainer. Okay, so they look very different. This one talks, so I'm going to let this one do the talking for me.
This contains no needle or drug. If you are ready to use, pull safety guard. To inject, place black end against outer thigh. Firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete. This trainer may be reused for training purposes. Place the red safety guard and gray. This trainer may be
Great. So now it's hard to talk over this one. So, but I'll just tell you sort of a few things. So, you saw it's really the same. The location is the same. The real difference is that it talks. If you know how to use it, you don't need to wait for all of that. So I'll just show you that you could just, if you knew how, then you could just take it out, take the red off, and then
outer thigh. 5, 4, 3, 2, 1. Injection complete.
So it still talks a bit because,
It's reused for training purposes. Replace the red.
Great. And then the real one. So the real one says the same. It just, of course, doesn't say the part about it being a training device at the beginning. So, what's neat about this is that it kind of walks you through it. The one feedback I get from some people is that some people think that all of that talking might make them not use it in a restaurant or something like that. I don't know. I mean, I think if you're having an allergic reaction, it's probably not unreasonable for people to know about it. So, and then this one, of course, people are often very familiar with it. So you probably did see, I did touch the back of this one a little bit. Maybe I was trying not to, but just its form factor, I do find that I end up touching the back a little bit. It's a little bit different because this one, the lid is where the needle is, right? I just really want to highlight that the Allerject, you take the red bit.
Outer thigh. 5, 4, 3, 2, 1. Injection complete.
There's no real way to make it stop talking, but
This trainer is for training purposes.
I just really want to highlight that the part that the needle is at in this one is what you're removing, whereas on the EpiPen, it's the back that you're removing. Because by removing the back, by removing this pin, what it's doing is allowing that when you push on the front, it can sort of trigger the spring. So, if this blue bit is on and I try to trigger the spring, it won't trigger, see? But if I pull the blue bit off and then I push, then you hear that click. So you're taking the back off the epinephrine, so the EpiPen, and you're taking the front off the Allerject. That's, I think, the main, the other differences are probably evident, but I do like to really, really highlight that difference. And again, just to build the location, the positioning ideally is not standing, right? So ideally it is sitting or even better lying down.
Right, that was really great. And again, really helpful because when you think about doing a demo or practicing with it, you're just kind of walking through doing it by the steps. But when you're in an emergency situation or having a reaction, it's those common things you don't think about, like where's my thumb, where are my hands,
Yes.
and how am I holding it. So I think that's super
And
helpful.
I would love people, and you mentioned at the beginning, I would love people to practice with their devices, you know, practice with the demo, and just think about how would you give it. I really, really, you know, want to highlight you don't need to touch the back. The back has, you're not pressing a button in this. Neither one are you pressing a button. You're triggering the device by pushing it onto the leg. That's what triggers it. Yeah.
And even I've heard of some people who take expired devices and will inject them in oranges or other things just to get the feel of what it's like with the live device.
Absolutely.
So we have had some questions come in. One of the ones that I'll ask came in a little bit earlier, actually. It was asking, what do you do if you're having an anaphylactic reaction, but you're allergic to an ingredient with epinephrine or inside the ingredient with it? The question was ingredient with epinephrine. Do you have a suggestion, like if you're allergic to epinephrine?
So being allergic to epinephrine, so the epinephrine itself is you wouldn't be able to be allergic to epinephrine itself. It's a you know, the other name for it is adrenaline. So often the pharmaceutical name is epinephrine, and then the one we make ourselves is adrenaline, but they're the same. So I think I would first and foremost suggest that you see an allergist to assess whether you're allergic to you know, one of the ingredients in epinephrine, just to make sure, because it would be unusual. There are certainly people allergic to antihistamines, so I don't want to say that it's impossible, but it's I would suggest that is very carefully evaluated, because in general there's no contraindication to epinephrine if it's required for an allergic reaction.
Okay. Yeah, and this person did say if they were allergic to ingredient within epinephrine, what do you do? But I think that's best answered personally, right, through their allergist.
I think it would just be really important for that to be a very careful, comprehensive diagnosis. And if that was the case, I'm sure the allergist would give specific advice for that extraordinarily rare situation.
Okay, perfect. And you alluded to some of this a little bit earlier, but do anaphylactic reactions always happen within minutes after exposure?
Yeah, so that's a great question. It doesn't always happen minutes. It can happen up to a few hours after, and you know, maybe in very rare cases longer. But by the time you get to about 3 hours after the exposure, it would be extremely unlikely to have anaphylaxis. In terms of it coming back, though, that's a little bit different. So, you know, we definitely see people that have an allergic reaction, you know, within minutes to hours of the exposure, and then it comes back we call that a biphasic reaction, or where it comes back. So we definitely need to be thinking about the risk of anaphylaxis, you know, for up to about 24 hours after a reaction. And there are some particular situations where the reaction can be quite delayed. So there is one that's quite well known called alpha-gal allergy, where the classic story is that somebody eats meat and then, you know, for dinner, and then wakes up in the middle of the night with an anaphylactic reaction. And although that's very unusual in terms of the delay in timing, it's quite common for that particular allergy. So you know, when it is that delayed and that removed, then when you see an allergist, you often get all of these questions about meat or about, you know, other unusual exposures that might be those rare cases. In general, it's within minutes to hours.
Okay. So how much time do you have to treat an anaphylactic reaction? Once you realize what's going on, do you just take your time? Do you rush? Like how?
Certainly the sooner the better, because we know, thankfully, very severe outcomes from anaphylaxis are thankfully very rare. But when they're analyzed together, one of the most common themes is a delay in the administration of epinephrine. And that really that's where all this comes from. We are really trying to prevent a very rare event, but we know that one of the best ways to prevent that rare event is to give it early. And that's why, in general, if in doubt, give it. And some people may know that many, many moons ago, when on my very first day as an allergy resident, I actually did this demonstration, not through Facebook Live, but did this demonstration with the real one. I was not familiar with the way they looked, and I was asked to show a child how to use it. And so I took the back off and I hit it into my leg, and I gave myself the real one. So, and I was fine. I certainly suffered from embarrassment and my heart rate went fast, but I was perfectly fine. And so we would much rather that you give epinephrine than not. We really would. And we do also hope that will be another downstream effect of maybe, of some of your allergists will feel comfortable reducing the advice that you always, always, always have to go to the emerge. What we want is that you have a very low threshold to give the epinephrine, and really highlighting that that's the best treatment. I like to tell teenagers especially that if you had 1,000 allergists with you, if you had 1,000 emerge docs with you, if you were in the best hospital in the world, if you were having an allergic reaction, we would give you epinephrine, and you have it in your backpack or your pocket or your case. So please, please use it. We really hope that I know it's not about this, but we really hope that the new delivery devices, like the new delivery mechanisms of epinephrine, will increase and improve its urgent use, because we are aware that two of the biggest fears in life are public speaking and needles. And, every one of us wants to have those needle-free delivery of epinephrine, and, hope that comes to the market soon so that we can really get this med in as early as possible without that fear of needles. Yeah.
We just had a question come in about how do you show a younger child, so like a 4-year-old, about how to use their auto-injector?
Yeah, that would be very young. Every kid is different. We definitely see some incredible 4-year-olds. Yeah, I would suggest that young, most of the kids, they probably need an awareness that this is a device that can help them if they're having an allergic reaction. I think it would be a very rare 4-year-old who would be able to coordinate taking this off, pressing it, holding it, all of those kinds of things. So I do think that would be in the domain of a responsible, adult that's around them.
So how old would somebody be? Would you recommend that they start self-injecting? 7, 8?
Yeah, I think, there's a huge range of developmental abilities of children. Certainly getting used to it, around 4 or 5 is probably not unreasonable to start, to learn about it. I would think to be able to say that a child that's that young, sort of a preteen, is able to give it, I think I would want to see them demonstrate it for me to know that they can give it. And parents often have a very good idea of what's the developmental stage of their child. And certainly if we can do things like practice on the orange or practice with the demo and be very comfortable, then then you would have that confidence to say that they're ready. Otherwise, I think it's good to have some adult supervision and intervention there, especially when you think of just how many people, it's a stressful situation, and how many people get it wrong that are in the field. I can tell you, I have many physician colleagues who have injected their thumb, and as I revealed, I used the wrong one on my first day, but that wasn't my first day in medical training. I had already taken years of science and then done medical school, and I was physician. I had my internal medicine qualification, and then it was my first day of allergy training that I did that. So I think we don't want to just presume that people just know how to do this. It's really important to get used to the devices and have that kind of learned knowledge and that comfort with the device, so that if you ever need it, it's not the same boogeyman that it is if you've never looked at it or tested it out before.
We just had a question come in around signs and symptoms. So are initial reactions very evident in terms of signs and symptoms?
Yeah, it's a great question. I mean, sometimes people have very minor symptoms and then they build. Other times people, all of a sudden start wheezing. So I will say that there is increasing evidence that it is somewhat stereotyped for a person and a food, meaning that if you had a very particular sequence of events to peanut, then you tend to have, there is data now that looks like you tend to have that same reaction to peanut. That doesn't mean that if you have another food allergy like milk or egg, you may have a totally different sequence of events to that. But there does seem to be some replicatability and some consistency to what an allergic reaction looks like for a given person, for a given food. So there's some learning from that, but it still can be surprising. Here we do a lot of food challenges. We definitely see people who are where the child doesn't have any hives, and the parents say, "Oh gosh, last time he had an accidental exposure, he had lots of hives." So we can't trust it entirely. But if you've had an allergic reaction before, then you may have some feeling for what that looks like for you. We see all kinds here, honestly. So I think that, we often tell people, if you have a food allergy, carry your device. And if you don't have it with you, really ideally, you probably don't eat something that you don't know is 100% safe, because you do always want to. Food allergy to me is sort of, two elements. You're trying to prevent an allergic reaction, but you want to be ready for it if it happens. And so if you don't have the device with you, then you're not ready for if it happens. So don't take any chances.
I think that's a great thing. We often hear of parents who tell their children, if you don't have your auto-injector with you, then you're not eating. Like, don't eat. So that's something to kind of
because we all forget, right? I think it's important to normalize the fact that none of us are perfect. It's totally possible that you could leave the house and forget it.
Yeah.
So then don't let that be the day that you take risks, of things that you haven't eaten before, the things you haven't usually had. And so you really want to make sure that you that you have those two pieces. Try to your best to avoid it, but also be ready to treat. And since we're bringing that up in the vein of forgetting the device, I think it's helpful to know that it although of course it is a prescription device, and if you get the prescription, then usually you will have coverage for that. So children and young adults, it's covered in Ontario it's covered. The rest of the country it isn't, but still the prescription will often allow your drug coverage to cover it. But certainly in Ontario, you can actually buy epinephrine auto-injectors over the counter. So if for some reason you were traveling to the cottage and you forgot to bring it, yes, you can try to get your doc to send in a new script for you, but you can also probably buy it over the counter. Food Allergy Canada may know better than me what's the landscape like that in provinces other than Ontario.
Across Canada. Yeah, you can get you can buy it over the counter across Canada. So you can be run into the pharmacy and get
and get one. Now you'll have to pay out of pocket,
and
you won't have a prescription in that setting, so you may not be able to get that money back. But that might be more convenient than trying to hunt down a doc or driving all the way back. And so I really like to tell people that if you are in that position, you actually can go into a pharmacy and buy one, which I don't remember when I learned that, but I certainly have not always known that.
We have lots of questions coming in. So one question's come in on if you aren't sure that your child ingested their allergen or whether they're having a reaction, is it okay to give epi just in case? I think you answered this, but I think it's good to talk about it again, reinforce the point.
Yeah, I mean, So meaning there's no symptoms at all, or there's symptoms?
So I'm gonna guess in this case that there's some you don't know their symptoms, but you don't know if
Okay.
they've actually eaten their allergen.
Right. So yes, if there's symptoms, I think you can make your decision based on the symptoms. And so we often say, I mean, the way I kind of simply put it often is, 2 systems involved or 1 severe. Or another way we're starting to think of it now is if there's symptoms where it didn't touch. So, it may not be so surprising that, at the beginning we talked about the food touches the GI tract. And so, if you have an itchy mouth and your stomach hurts a bit and you vomit, that's, maybe makes sense because that's where it all touched. The minute that we see symptoms outside of where it touched, then we know that that you've absorbed it and it's going through the bloodstream and causing that reaction. So we give I advise to give epi for 2 different body symptoms, like 2 different body systems, like we talked about at the beginning, or any severe, or cardiovascular alone, respiratory alone, throat alone. Those are essentially, so I just want to highlight GI alone, like, so if somebody was repetitively vomiting, very severe abdominal pain, I would also give it in that situation. I'm just highlighting that's all where it touched, and so there is a trend now that for mild GI alone, we don't necessarily give epi.
This person clarified. So if there are symptoms, but maybe you're confused thinking, is it a cold? Is it a flu? Could it be attributed to something else? Because if you're not thinking about,
Right.
oh, have you ingested something? So I guess it's how do you distinguish between illness and anaphylaxis if you're not sure?
Yeah, that's a great, I mean, look, if it's a sudden onset, all of it, the child was fine and all of a sudden they're very, stuffy and they're known to have a food allergy and, and then they also have another system involved, if they're, then I would give it. I mean, in general, if you're not sure, give it. It's, in a young child, it's not going to be harmful. In an adult, it's not going to be harmful. There's no contraindication for the use of epinephrine, even in people with cardiac disease, even in people with, other, issues that might make it slightly higher risk. It's there is no contraindication for the use of epinephrine in the setting of anaphylaxis. And so if you think somebody's having anaphylaxis, so multiple systems involved, or a severe system like respiratory, so breathing, heart, or throat, you'd be better to give it.
Okay. So what does epinephrine do that antihistamines do not?
Yes, excellent. So antihistamines are not the treatment for anaphylaxis. Antihistamines block histamine. And so what they're doing is, I often sort of do this with my hands where I show that this is a mast cell, which is one of the main cells in our body that is driving the allergic reaction. And these mast cells have IgE stuck to the top of them. And so when you eat what you're allergic to, then the food binds that antibody and then causes the mast cells to release the histamine. And what you're doing with an antihistamine is just blocking that downstream, blocking the effect of the histamine. And so whereas and it takes a while. So you can imagine, that's an oral medication. You're going to have to take it. It's going to take 20 minutes or so, maybe half an hour for it to get absorbed. And in all that time, it's not really doing anything. Plus, it really has never been shown to do anything for the worrisome symptoms of anaphylaxis, the breathing symptoms and the cardiovascular symptoms. You don't hear about somebody having, wheezing because of asthma and telling them to take an antihistamine, right? So, it isn't the treatment for the symptoms that we're worried about, and it takes too long to act. So then why do we give it at all? So we often do give it, as well, because it can be helpful for comfort, helpful for itch, those kinds of things. So, but epinephrine is completely different. For one thing, it's being delivered intramuscularly. And so you're getting it very quickly, within minutes into the system. And then it is counteracting all of the things that we worry about in anaphylaxis. So the tight lungs, it's opening them. The dilated vessels where you see, redness and flushing and hives, and can see low blood pressure and that difficulty in the heart pumping, then it's tightening all of that. And so it is really directly acting in the opposite positive way to counteract the symptoms of anaphylaxis. And, certainly in our institution, we have removed all other meds from what we call our anaphylaxis kit to only have epinephrine on it, to really, really stress the point that that is the treatment of anaphylaxis. Anything else is for comfort and it's not the frontline treatment.
That's a great explanation. We had a question come in about, can it be an anaphylactic reaction if the food wasn't ingested? So if you have a food allergy, you didn't ingest the food, but you're having, I don't know, potentially symptoms, can it be anaphylactic?
So that would be very unusual. In general, you need to eat the food to have an allergic reaction. There are some situations that have been described. So, we never say never in medicine, but so there are some situations. One, for example, that's been well described is people that are allergic to fish or shellfish. Then the cooking can put that up into the air. And then if you inhale that air, then you can, so the steam, I should say, where the protein is actually in that steam, then you can get some absorption of the allergen in that way. There have also been situations, where there's enough of the allergen on a surface or a countertop where you've touched with your hand and then touched mucous membrane, so the mouth, and had that little bit of absorption, which has been enough. And then in very rare cases, it's been described that having tons and tons and tons of skin prick testing, for example, can deliver enough allergen to cause a reaction. But the vast majority of cases requires ingestion. And so controlling ingestion will really massively control the risk of having anaphylaxis. Usually, I think you would know if you're in one of these unusual situations, where something is being cooked and can deliver the allergen. I want to make sure I distinguish that from the smell. So if I open a can of peanut butter, you may be able to smell that, but that smell is not the same because the smell isn't putting the protein up into the air the same way it would be if I was, sizzling it and boiling it and, sending that steam up into the air, like it's been quite well described for fish and shellfish. So I hope, and I think Food Allergy Canada has some pretty nice resources about, can the smell of an allergen cause anaphylaxis, and also, the role of ingestion. And that really is the dominant way of being exposed to foods.
That's a great explanation. Is one epinephrine auto-injector better than the other for treating a reaction, or are they equal in effectiveness?
The best one for you is the one you like better, because the one that you're much more likely to carry and the one that you're more likely to use. And so, it's exactly the same drug. And it really comes down to, if one of these is more appealing to you, in terms of the carriage and in terms of the use, then that's the one that you want. Some people have both because they feel like maybe the babysitter could do with the talking, of this one, but they have a great familiarity with this one. And so that's a very personalized decision, and they have exactly the same drug.
We had another question come in about, and this is again, understanding signs and symptoms and when to use epi. So what if a child has vomited once and has hives, but nothing severe, and those are the only symptoms? Would you still give epinephrine?
Say that again.
So what if a child has vomited just once and has hives, but nothing severe? Are those, and those are the only symptoms, would you still give epinephrine?
So for most situations, you know, let's put it like this. Vomiting alone does not necessarily meet the definition, does not typically meet the definition of anaphylaxis. But, you know, certainly repetitive vomiting, severe abdominal pain, then often we would give that. And, you know, I would probably use a little bit of a judgment call of where am I, and how far away am I from medical care? Just because it's hard to predict what happens next. And so, you know, if I'm at a cottage 3 hours away, I might be more apt to use the best treatment that I have than not. So, you know, officially you wouldn't have to give it for that. But, you know, I always think it's better to give it than not.
How do you know when a baby is experiencing anaphylaxis? Because they can't talk to you or tell you necessarily that they're not feeling well.
Yeah, so that's a great question. So babies can still have the skin symptoms. So we can definitely see, you know, lip swelling or hives or scratching, you know, as long as they're not, you know, like a little bit older where they can kind of organize themselves to scratch a bit. So we can see those symptoms. We can also see wheezing. So there's certainly some of the classic symptoms that we described that you can see, or vomiting. The abdominal pain can be very tough in a baby because I find that many of the babies, you know, have these episodic issues where their stomach hurts and then they just need to release some gas and then they're happy again. And so that can be tough, and often moms are better at, you know, knowing what their child is like. So many of the symptoms that we describe are relevant to babies. But on top of that, babies often have a significant behavior change. And so if all of a sudden they become very, very clingy or very different, or you know, tired when you don't expect them to be, those kind of symptoms can be indicative of an allergic reaction. And really, you know, as a community of allergy, it's really only been in about the last 10 years or so that we've been learning a lot about infant anaphylaxis. So, but those are the particular ones, this very significant change in behavior that we can see in the little kids. Mm-hmm.
What dose do you give a child who weighs less than 15 kilograms or 33 pounds?
Yeah, so that's an excellent question. So some may know that in the US, they actually have, so just to recap, this is 0.3. This, and then the junior is 0.15. So same for both of them. This is 0.3, the junior is 0.15. In the US, they actually have 0.1 in this, in the Allerject brand. We don't have that here. We have a statement from the Canadian Society of Allergy and Clinical Immunology from a number of years ago that addresses that question exactly and really puts a lot of thought into what should you do in the very, very low weight groups. And it thoughtfully thinks about, well, you know, should we be prescribing epinephrine that we draw up to the exact amount per weight, and then you'd have to give it with a needle and syringe? Or do we just use Epi Junior? And it's a very thoughtful discussion that, with all things on balance, it really makes a lot more sense and is a lot safer to just use the Epi Junior. So that's what we do. Now, admittedly, when I prescribe it for somebody that low, I make sure to put a comment to the pharmacy that they recognize that I recognize that the child is less than 15 kilos and that it is a deliberate prescription, weighing the risks and benefits, and that having an auto-injector really just gives that immense safety around dosing and around the help with delivery and not seeing the needle, which so many people are scared of needles. And that, all things considered, it's a better choice than trying to get the absolute exact dose with people needing to fiddle with needles and syringes.
And then we did have a question come in about expiry of devices. So so I'll ask a two-pronged question. So can I use an expired device if I don't have any other options? And the question that came in was about how long after it's expired is it safe to still use it?
Right. So, you know, really you should use, you know, you should know that, you know, ideally look at the window and see that it looks reasonable to use. This one also, I believe, has a window. Yeah, where you can see the medication. So hopefully we're checking our supplies and trying not to have them expired. But if that was the only choice, then yes, you can. We used to kind of know that they were very good for quite a long time after expiry, but the companies actually changed the expiry dates in line with the fact that they know that the drug, that all the evidence that showed that it was good for quite a bit longer than the original expiry dates. They actually changed the expiry dates. So they're not, we don't want to kind of think, we used to be able to say, oh yeah, like 6 months, a year, it's basically the same, but they actually changed the expiry date. So ideally keep them within, but yes, if that's all you have, then it's going to be better to use than not using it.
And then I think the other part of the question was if, how long out, so it's expired, let's say, I don't know, 6 months, is it still good to use? Like, what time frame is it like, no, just don't use it, it's too far gone?
I'd probably still use it if it's the one I have. Yeah.
Okay.
But ideally you get a new one. I will also say that many people, some parents have given me these tips, where you can, if you're refilling these, in advance, you can ask them to give you a long expiry one, and check it when you pick it up. And I think many of the pharmacies, many of them have a rule that they give you that it needs to be a year or so from the date that you collect it. And so you don't want to refill these too early because then, if your one now is good till December 2024, you don't want to go pick it up now, and it's probably going to be, June 2025. So you do want to time it a little bit, and you can definitely ask them to give you one with a decent expiry date on it.
Okay, perfect. Thank you so much. It was extremely helpful to have you answer these questions for your participation. I'm going to talk a little bit, but then I'm going to loop back to you just to talk about the kind of key takeaway messages. I know we're a little bit over, so hopefully you're still good for another couple of minutes or so, Dr. Upton. Okay. So like I mentioned, we've covered a ton of information. You can find additional resources on our website, foodallergycanada.ca. As I mentioned when we began, it is Food Allergy Awareness Month right now, and we are focusing on anaphylaxis education by doing sessions like the one we've done today. We have relaunched our Know It, Treat It campaign, which is really all about empowering all Canadians to recognize and treat anaphylaxis by sharing their real life stories and experiences. So you can go to our site and see this immense gallery of people sharing their experiences. So you can also participate in the campaign by sharing your story, and you can get a chance to win a $100 Visa gift card. So find out more at foodallergycanada.ca/FAAM. You can also check out our resources like our videos explaining further. I know Dr. Upton was talking about the mast cell earlier and walking through that process. We have a video with Dr. Philippe Béget, who explains what's happening to the body when you have a food allergy and what happens when you have anaphylaxis. We have the 5 emergency steps that we reviewed earlier, our epinephrine sheet, and signs and symptoms sheet, along with other resources and tips on food allergy and anaphylaxis. So check it out. And as Dr. Upton mentioned earlier, don't forget to order free training devices and practice. So if you do need it, it becomes second nature and you're not fumbling around as much. So Dr. Upton, we've covered so much in this session. Can you summarize the top points you want to make sure that people really take away from the session today?
Absolutely. Maybe I'll first say one of the top ones is when you're thinking of trainers, always make sure you look and see that it's the trainer for sure. Yes. But I think if I had to summarize, I really would want to, learn about the signs and symptoms of anaphylaxis. But if you're unsure, the safest choice is to use the auto-injector. The earlier you give epi, the better the outcomes are. And that's really why we push it so much. It is recommended to have a second dose on hand, just in case you need that, and to practice with the training devices so that you know how to use them. And I totally agree that there's lots and lots of resources on Food Allergy Canada that you can kind of read at your leisure, or look up specific things that you're wondering about to just try to help you be prepared and be confident. So thank you so much.
Thank you for the summary. And like I mentioned before, this will be recorded, so you can watch it again. You can share with others. You can follow along with Dr. Upton as well on with your trainers. So as those of you in the audience are aware, Food Allergy Canada is a non-for-profit charity. We are completely reliant on donations for the support of the work that we do, like this session today. So if you can consider a donation to our organization, we would very, very greatly appreciate it. You can visit foodallergycanada.ca/donate. We'd also like to thank our supporters for this session, the Schroeder Foundation, the Peanut Bureau of Canada, EpiPen, and viewers like you. This now concludes our Facebook Live event. Thanks for joining us and participating.
Thank you.